All right, so my task was to go over about 10 trials in the next 8 minutes, so this is going to be really challenging, but we'll condense it all down into sort of high-level summary, and that really tells us how rapidly the early stage setting is also expanding, and I think it's extremely exciting, right? We're seeing all of this activity in the metastatic setting now translating into the curative setting, and I think this will have significant impact, and we're starting to see that impact. So this is a summary of the various approaches that are being tested in the early stage setting for advancing oral SERD or novel SERD therapy. And it really comes down to an upfront versus a switch strategy. Of course, our current approach, particularly for our higher risk patients, is endocrine-based therapy plus CDK4/6 inhibition, and then to continue on the endocrine monotherapy. So in terms of oral SERD development, trials are now testing either a switch strategy where you are on that endocrine therapy, CDK4/6 inhibition, for an allotted period of time, a couple of years, and then you switch to the oral SERD, or an upfront strategy, either with or without a CDK4/6 inhibitor, and starting that SERD right away. And I think this is interesting because, as I think you pointed out, Heather, in the early stage setting, we don't expect or anticipate there to be a high prevalence of ESR1 mutations, especially before you've used an aromatase inhibitor or on a short time on that aromatase inhibitor. So I think we'll also get a lot of really interesting data about resistance mechanisms from the various trials going on in this space, and when that ESR1 mutation emerges, and then the subsequent efficacy of the SERD in those various settings. Now, with that being said, we did see some, I would say, very exciting data from the lidERA trial. This is really our first readout of an oral SERD trial in the early stage setting. So I'll just remind folks of the trial design here. So this was patients with stage 1 to 3 early stage breast cancer. Now, one had to be high risk, and I'll point out some of the features there, or node positive disease. And patients were randomized upfront to giredestrant, novel oral SERD, or standard of care endocrine therapy, which could have been tamoxifen or an aromatase inhibitor. And a few things to point out here. As I mentioned, stage 1 high risk was allowed. Premenopausal patients were also eligible, and ovarian function suppression was required for premenopausal patients. In the standard of care arm, I mentioned either aromatase inhibition or tamoxifen were allowed, and we can talk about the implications of including both of those agents in the control arm. And then finally, interestingly, prior endocrine therapy with a CDK4/6 inhibitor for up to 12 weeks was allowed, but if that was the case, the CDK4/6 inhibitor had to be stopped upon randomization because that combination was not allowed during the trial. So here are the baseline characteristics of patients. You can see that about 40% of patients were premenopausal, and about 20% of patients were node negative. Here I'll highlight the population in the medium versus the high risk category, and there you can see about 70%, so a predominance of the population were in that high risk category, which was really defined by anatomic staging. Now let's take a look at the primary endpoint here, invasive disease-free survival. And ultimately, it's really that hazard ratio that we have to pay attention to, because this is still a bit of an early look at the data here, but there you can see that the hazard ratio was 0.7, favoring giredestrant over standard of care endocrine therapy. And these points were pointed out by the discussant, Lisa Carey, which I think are important to keep in mind here, that the curves do separate, even though we're waiting for longer-term outcomes. And when we look at other key endpoints that support this primary endpoint, like distant recurrence-free survival, you see a consistent story as well. Now, one of the things that I don't have on the slide here is that when you parse out the control arm endocrine therapy, whether it was tamoxifen or an aromatase inhibitor, you do see that that magnitude of benefit was even greater if you're comparing to tamoxifen. So we do have to keep in mind that perhaps a little bit of a more inferior therapy in this moderate to high risk population could be contributing to some of this delta benefit that we're observing with giredestrant. The other key consideration here, of course, is tolerability, and I think one of the exciting things about the availability of oral SERDs or the development of oral SERDs in the early stage setting is that we know that patients do struggle, unfortunately, with adjuvant endocrine therapy. Many of them discontinue adjuvant endocrine therapy, certainly AIs due to arthralgia, weight gain, and other things. So another potential is the better tolerability of giredestrant in the early stage setting. So there you can see some summary points here that the rate of dose interruptions was slightly higher in the giredestrant arm compared to the control arm, but the rate of discontinuations was actually higher in the standard of care arm. And when you look specifically at arthralgia, interestingly, if you look down at the AE plot there, you can see that the rates of all-grade arthralgia were similar between both arms, but the rates of discontinuation due to musculoskeletal symptoms was lower with giredestrant versus standard of care endocrine therapy, 1.8% versus 4.4%. So this suggests to me that clinically impactful arthralgia or musculoskeletal symptoms were likely to be lower in the giredestrant arm versus the standard of care arm. Also keeping in mind, again, the inclusion of tamoxifen, where you see less arthralgia in the control arm. And then finally, bradycardia is something that we think about with some of the oral SERDs. Fortunately, it was pretty uncommon here, 10%, and largely grade 1 with giredestrant. So the summary for lidERA here is that ultimately this is really our first advance in adjuvant endocrine therapy in the last 2 decades here. There was looking at that hazard ratio, there was a 30% proportional improvement in IDFS, as well as other cancer-specific endpoints telling a consistent story. And this is an early look. That benefit, particularly in ER-positive primary disease, is likely to grow as we continue to have longer-term follow-up. Now, what's also interesting here is that we don't have combination data with CDK4/6 inhibitors from the lidERA trial. That was not allowed. Dr. Carey suggested in her discussion that for our high-risk patients, we may consider AI plus CDK4/6 inhibition and then switching to giredestrant, but of course this is not how the lidERA trial was designed. So I think one of the key questions there is, if we do take that approach, is there really an additive benefit, or should we stick with the evidence-based approach and start up front with giredestrant monotherapy? And so far we do not have predictive biomarkers to help us address that and other questions. And I think it's interesting here because this was an upfront strategy. So we know that most of these patients probably did not have ESR1 mutations, again raising the question of we're probably not seeing ESR1 specific activity in this adjuvant trial, which is in contrast to the metastatic setting. So this is a busy slide here, but there are several other trials in this space here, and I'll just point out a couple here. We've talked about lidERA already. Camizestrant is also being tested in the adjuvant setting in Canberra 2 and 1, and then Elegant is testing elacestrant in the adjuvant setting as well. Now note that some of these trials employ a switch strategy versus an upfront strategy. So camizestrant is being tested both as an upfront strategy as well as a switch strategy, elacestrant as a switch strategy, so starting with that standard of care endocrine therapy and then switching. And then we're also seeing trials that are testing the combination of oral SERDs with CDK4/6 inhibitors in this space. So this landscape is going to change very quickly and very soon. There are also trials that are testing these approaches in the neoadjuvant setting as well. And that really does highlight, going back to our original discussion about ctDNA-guided therapy decision-making, this is also being tested in the early stage setting. Now, these are challenging trials, some of them to accrue to, because the rate, again, of ctDNA positivity tends to be low. But we reviewed yesterday, for example, the DARE trial in the Crossfire session. There are other trials in this space that are also testing whether or not we should escalate therapy upon detection of ctDNA positivity, and I really think those are the trials that we actually do need to answer this debate that we were having about whether or not we should routinely be testing for ctDNA or MRD in the early stage setting.